Let's go over the 3-question warm-up for Pulmonary 3. First question, a 45-year-old woman complains of a malar rash and arthritis. The presence of which antibodies is specific for systemic lupus erythematosus? That would be anti-double-stranded DNA antibodies and anti-Smith antibodies. Next, what is the mechanism of type 4 hypersensitivity? Type 4 hypersensitivity is when you have T lymphocytes that are sensitized and then they come across antigen and release lymphokines. So this is your T cell mediated hypersensitivity or delayed type of hypersensitivity. And the last question, a 25-year-old woman presents with sudden monocular vision loss and slightly slurred speech. In the past, she has had episodes of weakness and paresthesias, but she is not currently experiencing those symptoms. What is the most likely diagnosis? So this is most likely multiple sclerosis. All right, now it's time for the lecture.
Welcome to another episode of Hey, Look at Me! I'm Dr. Lewis and I think I'm so great. Give me a break. In this video we're going to talk about hemoglobin, which plays a vital role in oxygenation. Without hemoglobin, the lungs would be pretty useless. The lungs are designed to deliver oxygen to the hemoglobin molecules so then the oxygen can be delivered to the rest of the body. Now remember, hemoglobin is made up of 4 globin proteins, 2 alpha globin subunits and 2 beta globin subunits. And each globin subunit is bound to heme. So hemoglobin has 4 heme molecules and 4 oxygen binding sites, and that's important. There's a T form, or a taut form of hemoglobin, which has a low affinity for oxygen. So the T form favors tissues. It's going to give up its oxygen very readily so that the oxygen is released to the tissues. The R form of hemoglobin is the relaxed form, and it has a very high affinity for oxygen. And hemoglobin shows what we call positive cooperativity, which means that once hemoglobin is bound to one oxygen, it's then more likely to bind to a second oxygen, and that makes it more likely to bind a third oxygen, and so on. So this accounts for the sigmoid shape, or S shape, of the oxygen dissociation curve. We'll see that shortly. So what determines whether hemoglobin is in the T form or the R form? So CO2, hydrogen ions, increased temperature, and 2,3-DPG all favor the T form over the R form. They all favor unloading of oxygen to the tissues. Now, what's 2,3-DPG? It's 2,3-diphosphoglycerate. You'll also sometimes see it called bisphosphoglycerate, or 2,3-BPG. It's the same thing. But anyway, CO2 and acidosis and increased temperature and 2,3-DPG all favor the conversion of hemoglobin from the R form to the T form so that oxygen will be unloaded to the tissues. This makes sense. As hemoglobin carries oxygen out to the peripheral tissues, like the muscle tissues, and they're working really hard, and they're using a lot of glucose and making a lot of CO2, you would want the hemoglobin to unload the oxygen at those tissues. So when hemoglobin gets near all that CO2 that's being made in the muscles and being put in the blood, that CO2 will cause the hemoglobin to convert from the R form to the T form. And since the T form has a low affinity for oxygen, the oxygen comes off of hemoglobin and it's free to diffuse out of the blood into the muscle tissue where it's needed. Likewise, muscles that are working hard are going to be making a lot of lactic acid and creating more lactic acidosis, meaning that there's going to be more hydrogen ions around. So again, that would favor the T form over the R form. Muscle action generates heat, right? So again, increased temperature favors the T form and unloading of oxygen. Now, we're talking about adult hemoglobin here, hemoglobin A. Fetal hemoglobin is made of 2 alpha globins and 2 gamma globins. And fetal hemoglobin actually has a lower affinity for 2,3-DPG than adult hemoglobin does. So as a consequence, the fetal hemoglobin has a higher affinity for oxygen. So with adult hemoglobin, 2,3-DPG is going to favor the T form and oxygen unloading. But the fetal hemoglobin has a lower affinity for 2,3-DPG, and it's going to start binding up all the oxygen that the maternal hemoglobin A is releasing. So that allows for oxygen exchange at the placenta. Now let's look at some oxygen hemoglobin dissociation curves and talk about the relationship between the partial pressure of oxygen in the blood and the oxygen saturation of hemoglobin. The first thing you notice about this oxygen hemoglobin dissociation curve is that it's sigmoid shaped, or S-shaped. That's because of positive cooperativity of hemoglobin, whereas you start to bind oxygen to the hemoglobin, it favors even more oxygen binding. So let's look at the blue line for now. The blue line represents normal saturation. So So for any given partial pressure of oxygen along the x-axis, a certain percentage of the hemoglobin molecules are going to be saturated with oxygen. So how do we measure PO2? Well, PO2 is basically measured as dissolved gas. So when oxygen goes into the blood, some of it's bound to the hemoglobin and some of it's just dissolved in the blood. Not all the oxygen in the blood is carried by hemoglobin. Just some of it's just dissolved in the blood, and we can measure that. So the PO2 is the partial pressure of oxygen, and we measure that with an arterial blood gas, or an ABG. So ABG is going to measure your PO2. Then how do we measure hemoglobin saturation? We measure that with a pulse oximeter. Pulse ox is a decent estimate of hemoglobin saturation. It's not 100% accurate, but it's a pretty good estimate. If you look at a PO2 of 100, that's pretty much normal, and around 95% of the hemoglobin is saturated there. But if you go down to a PO2 of 70, the saturation starts to drop off a little bit. And then going down to a PO2 of 50, you see the curve is getting steeper and steeper. So going from a PO2 of 70 to 40, you're going to have a big drop off in your hemoglobin saturation, much bigger than you would, say, going from 100 to 70. From 100 to 70, you're decreasing the PO2 by 30 points, but the hemoglobin saturation really isn't changing that much. But when you decrease PO2 by another 30 points, going from 70 down to 40, you're going to see a much bigger change in the hemoglobin saturation. Then, going back to the factors that favor the T form over the R form, what happens when you shift this curve to the right? Let's take a look at a PO2 of 60. On the normal curve, the blue curve, a PO2 of 60 corresponds to a hemoglobin saturation of almost 90%. But look at the red curve. When you shift the curve to the right, at a PO2 of 60, the hemoglobin is going to be less saturated, only about 80 or 82%. So again, when the curve is shifted to the right, there is less hemoglobin saturation for any given PO2 than before the curve was shifted. So what kinds of things will shift that curve to the right? All those things we said favor the T form of hemoglobin over the R form. Carbon dioxide, elevated 2,3-DPG, increased metabolic needs like exercise or activity, hydrogen ions or acidosis, and high temperature. And again, all these factors favor less hemoglobin saturation and favor oxygen unloading. Now let's talk about shifting the curve to the left. Let's look at the green curve. You can see here that at any given PO2, more hemoglobin will be saturated than on the normal curve. Look at a PO2 of 60 again. At a PO2 of 60 on the green curve, the hemoglobin saturation is up to around 93%. So what things shift the curve to the left? All the opposite things: decreasing CO2, decreasing 2,3-DPG, decreasing metabolic need, decreasing hydrogen ion, which is alkalosis, and decreasing temperature. Those are all going to shift the curve to the left. And then again, we said that fetal hemoglobin has a higher affinity for oxygen than adult hemoglobin. Another way to say that is that fetal hemoglobin's dissociation curve is shifted to the left. One of the reasons why it has a higher affinity is because it has a lower affinity for 2,3-DPG. So lower affinity for 2,3-DPG means a higher affinity for oxygen and shifting the curve to the left. Now, this is a pretty high-yield topic to be able to understand this relationship and how all these different factors affect the curve. Next, I want to talk about a couple of toxic forms of hemoglobin: methemoglobin and carboxyhemoglobin. So these are both forms of hemoglobin that can't carry oxygen as well as regular hemoglobin, and this leads to tissue hypoxia. So methemoglobin is the oxidized form of hemoglobin. It has iron in the ferric form. Now, one student suggested that you can remember that ferric is the 3+ form of oxygen because ferric ends with the letter C, and C is the third letter of the alphabet, so ferric is 3+. Or if you take the S in ferrous and you write it as a 2, that can help you remember that ferrous is the 2+ form, and the ferrous form binds to O2 better. And that means that the 3+ ferric form, which is the methemoglobin form, and that does not bind oxygen as readily. So methemoglobin has decreased affinity for oxygen, but it has increased affinity for cyanide, and this can be very clinically useful. Giving patients nitrates like nitroglycerin or sodium nitroprusside will start to oxidize some of the patient's hemoglobin to methemoglobin. So if you have a patient with cyanide poisoning, you can give them nitrites to oxidize hemoglobin to methemoglobin. And since methemoglobin has that higher affinity for cyanide, it's actually going to go throughout the body and pick up cyanide. Basically, you're converting your hemoglobin into a cyanide transport mechanism. And you can actually get a cyanide antidote kit, which has amyl nitrite that you make the patient inhale, and also sodium nitrite that you give IV. Then, just so you've heard of it, the second step of that antidote kit is to give thiosulfate, which binds to cyanide and forms thiocyanate, which is renally excreted. And there's some other drugs that will bind to cyanide directly as well. So, what causes methemoglobin? Methemoglobin is typically caused by medications. Let's look at number 4 in your study guide. What substances are known for causing methemoglobinemia? Again, one of the most common causes is nitrates and nitrites. So if you have a patient having an MI, and that patient's put on a nitroglycerin drip, then that's more likely going to cause methemoglobin, an elevation of methemoglobin over time. Then some other drugs that can cause methemoglobinemia include anti-malarial drugs like chloroquine and primaquine, dapsone, sulfonamides, local anesthetics like lidocaine can do it, and also metoclopramide. So nitrates like nitroglycerin are among the most common offenders because a lot of people are on nitrates. Fewer people are chronically on these other drugs. But if you have a patient coming into the hospital with an MI, you might put them on that nitro drip to relieve their chest pain while they're waiting for their cardiac cath or to control their symptoms. So it's not uncommon to have a patient on a nitro drip for several days. That's more likely going to increase the methemoglobin level. So what do you do in that situation? Well, methemoglobinemia can be treated with methylene blue, and then vitamin C is another important antidote. So remember, methylene blue for methemoglobinemia and also vitamin C. There's one other drug that can be used to gradually lower methemoglobin levels, which is the H2 blocker cimetidine. Now, it doesn't work very quickly, so you're not going to use it for acute methemoglobinemia. But if you have a patient who's going to be on a long-term course of one of these drugs that might induce the methemoglobinemia, like dapsone. Maybe you have an AIDS patient who's going to be getting dapsone or sulfonamides as prophylaxis against pneumocystis pneumonia. So you might put this patient on cimetidine with the dapsone, so they're going to be less likely to get methemoglobinemia. Then the other clinically important toxic form of hemoglobin we want to talk about is carboxyhemoglobin. So this is a form of hemoglobin that's bound to carbon monoxide instead of oxygen. So hemoglobin's affinity for carbon monoxide is about 200 to 250 times greater than its affinity for oxygen. So in the presence of carbon monoxide, all the hemoglobin will preferentially bind to that rather than binding to oxygen. This causes a decrease of oxygen binding capacity with a leftward shift in the oxygen hemoglobin dissociation curve. It's going to decrease oxygen unloading to the tissues. So carbon monoxide will pretty much shut down delivery of oxygen to the tissues. The tricky thing and the scary thing is that you can't diagnose carboxyhemoglobin with a pulse ox. A patient could come in with carbon monoxide poisoning and tons of carboxyhemoglobin, very significant hypoxemia, but they could still have a normal pulse ox indicating hemoglobin saturation. But the hemoglobin is saturated with carbon monoxide instead of being saturated with oxygen. So that's pretty much it for oxygen and hemoglobin. It's a short lecture, but it's kind of intellectually intense. Hope your brain's not too fried. So let's stop and do the end of session quiz before you overheat. All right, let's look at these answers. First question, which form of hemoglobin A has a high affinity for oxygen? And which one has a low affinity for oxygen? So there's the R form, or the relaxed form, which has a high affinity for oxygen, and the T form, or taut form, which has a low affinity for oxygen. Next, what substances tend to shift the oxygen hemoglobin dissociation curve to the right? So we said carbon dioxide, elevated 2,3-DPG, increased metabolic needs like exercise or activity, acidosis, and high temperature. All these are going to favor oxygen unloading. And then the last one, what's the treatment for methemoglobinemia? You're going to give methylene blue, and also vitamin C can help. So that's it for Pulmonary 3. I'll see you next time.
Hello there. Apparently my mind and combat skills are so amazing that headquarters asked me to make this short training video for you all. Today's question is, what is the treatment for methemoglobinemia? First, stop the offending agent if possible, which of course it is. Second, administer methylene blue, preferably in an IV injection. What? This is a dragonberry teeny. Lesson complete.